407 years ago. Okay, gang, it's 12:20. It's time to get going. I hope your Thanksgiving was all that you hoped it would be, and even more. But it's now time to return to the task at hand. So I finished the digestive system. The link is on Blackboard. Please listen to it, watch it when you get a chance. And we are in chapter, I believe it's 17. We're in chapter 17. And we will try to get through that as fast as possible. We only have 4 classes left, and we have 2 chapters left. That's a pretty tall order. So the kidney is not a simple organ system to study, but we'll do the best we can with the time we have. What we don't get through, we will simply try to fill in as best we can by the means. Let's have a word of prayer. Father, thank you for this day, snowy though it is, slushy though it is. We pray you revive us from the slumbers of relaxing, not doing much, not having much of a schedule. Now I have a schedule again. We're in the home stretch, Lord. We see the end of the semester. Guide us there. Help us get there. Help us finish strongly. Help me to write a good final, and help us to be ready for a good final. In Jesus' name, amen. All righty. So the urinary system consists of the kidneys, the ureters that connect the kidneys to the urinary bladder, and then the urinary bladder is emptied by the urethra. The workhorse of the urinary system are the kidneys. They are these paired bean-shaped organs. They're kind of the water purification plant of your body, if you want to think of it that way. They regulate blood pH, blood volume, blood pressure, osmolality, and they also produce hormones. The kidneys are located between T12 and L3 vertebrae. They're protected by ribs 11 and 12. Those are the floating ribs. The floating ribs, if you feel the bottom of your rib cage and then go back and then feel these other ribs that aren't connected to that larger cage, those are your floating ribs. Some models have those removed to try to bring make their body smaller so that they look skinnier. Ribs are about the size of your fist. They are retroperitoneal. That simply means that they sit behind the peritoneal membrane. They're alongside the vertebral column, as you can see in this picture right here. The right kidney, you'll notice, is lower than the left kidney. That's to make room for the liver. And the middle of each kidney As you can probably see here, we have this little indentation here. That is the renal hilum, hilum, H-I-L-U-M. This is the entry point for the ureter and the renal artery and vein and the lymphatics and nerves that innervate the kidney. The kidney is surrounded by 3 layers of tissue. There's a renal fascia. It's a thin layer of dense connective tissue that anchors the kidney to the body wall, the rear part of the body wall. There's a middle layer of adipose tissue that protects the kidney from trauma. And then the innermost layer is the renal capsule. The renal capsule. It's a smooth, transparent sheet of dense connective tissue that gives the kidney its distinct shape. A cross-section of the kidney shows you 2 main parts. There is an outer rim that forms the renal cortex, and the inner portion is the renal medulla. The renal medulla. The medulla, as you can see, is composed of anywhere from 10 to 18 renal pyramids. And these renal pyramids have their point at a so-called renal papilla. These point towards the center of the kidney, renal papilla, which would be right here. The renal papillae point into these calyces. There are minor calyces that merge into major calyces. These major calyces then drain into the renal pelvis. The renal pelvis. And the renal pelvis is drained by the ureter. So you'll notice here in this picture, all this is yellow. That's essentially where the urine is collected and drained. The urine is then drained by the ureter. The renal cortex, you can't really see it here, is divided into an outer cortical zone and an inner juxtamedullary zone. So if we were to draw it here, if you imagine, there's kind of a little zone around each of these pyramids. That'd be the juxtamedullary zone. Then the outer cortical zone would be from here to here. All right, any questions so far on the structure of the kidney? Each pyramid and the cortex above it is called a renal lobe. A renal lobe. This probably shows the juxtamedullary field a little better. That's a juxtamedullary cortex. Here's the outer cortex here. like that. The kidney is going to filter about 150 liters of blood every day. And if there are 5 liters of blood in the body, that means the entire blood volume gets filtered about 30 times a day, which is more than once every hour. So think about this, folks. In the hour you're going to listen to this lecture, your entire blood will be filtered at least once by, more than once by the kidney. Pretty remarkable. All right, the kidney is composed of these structures called nephrons. Nephrons. You can see them here. These nephrons are the little mini organ of filtration in the kidney. We'll talk more about the structure of these nephrons here. So there are about 1 million nephrons in each kidney. Each nephron is composed of a so-called renal corpuscle, and then the rest of it is the renal tubule. Renal corpuscle and renal tubule. The renal corpuscle is a site of blood filtration that consists of a Bowman's capsule, and then the blood vessel that comes in here is called a glomerulus. Glomerulus, and sometimes the renal corpuscle gets called a glomerular capsule for that reason. The renal tubule is broken into 4 main parts. The first part is the proximal convoluted tubule, called so because it's highly folded, highly convoluted, highly twisty. Then comes the loop of Henle, loop of Henle. Then we have the distal convoluted tubule after the loop of Henle. And the loop of Henle, by the way, has 2 limbs. There's a descending limb and an ascending limb. These 2 limbs have different functions. Then there's a distal convoluted tubule, which empties into the collecting duct, and the collecting duct will empty into, it'll go down to the renal papilla, which empties into the calyces. Now, the urine that is produced, the filtrate that's produced by the kidney, is going to release the urine into the ureter. The ureter is not just a simple tube, it's a muscular tube that is going to undergo peristaltic contractions. It will push the urine along down to the bladder. Into the bladder, you have the so-called ureterovesicular junction. And if we look at the ureterovesicular junction, So the bladder these ureters come in like this. And if we look at this from the side, essentially the ureter is going to empty in this fashion here. Why does it do it this way? Because when the bladder fills, then the pressure will cause this flap to shut like that. So this becomes a one-way valve. That way you do not get urine leaking back up this way. And some people have a deformation of this ureterovesicular junction that permits urine to move back up the ureter, and that is called vesiculo-ureteric reflux, or VUR. People with VUR are at an increased risk for UTIs, urinary tract infections. They're also at particular risk for infections of the kidney, which are called pyelonephritis. Those can be very severe and they can be very difficult to treat. Now, let us talk about the micturition reflex. So the bladder has mechanoreceptors that are in the wall of the bladder. The bladder can hold about 750 milliliters of urine. So about, not to be grotesque, but about the volume of a bottle of wine. So 750 mils, that's its capacity. However, once the bladder is filled to a volume of between 300 to 400 milliliters, the stretching of the bladder sends a signal via the sensory parasympathetic nerves to the micturition center in the spinal cord. This is between S2 and S3. So micturition center, I'm just going to say MC. This will then send signals via the hypogastric nerve through an interneuron to the smooth muscle of the bladder. This smooth muscle of the bladder this is called the detrusor muscle. The detrusor muscle. It causes the detrusor muscle, as you see here, to relax. The muscles, however, at this little triangular bit here, where the ureterovesicular junction is, there's a little triangle of tissue here. That's called the trigone. The trigone. The trigone is going to contract and it's going to open the internal sphincter. The urine, therefore, is going to move down here, but the external sphincter is going to be shut, so it will not go outside. So the urine, therefore, will be stored in the bladder, like this. And if it is not convenient to go to the bathroom, there is a pontine storage center in the brainstem, in the pons, and it sends a signal, again, through the pudendal nerve that innervates the external urethral sphincter. And that external urethral sphincter will be tightened and you will not leak urine unless you have a problem with this muscle, you had an injury or something like that, then you may leak. Now, what happens when you wish to void your bladder? When you wish to void your bladder, in the periaqueductal gray, also of the brainstem, you have the so-called pontine micturition center, the pontine micturition center. This will send a signal to the pontine storage center, and that inhibits this, which will inhibit the flexing of the external urethral sphincter. This micturition center will also send a signal that will cause the detrusor muscle to contract. So the signal through the hypogastric nerve is inhibited. That causes the detrusor to relax. Instead, you get a second signal, also through the pelvic nerve, that will cause the detrusor now to contract. So the detrusor muscle contracts, and the urine, with the relaxation here, the urine is now going to move to the outside. Damage to the bladder, damage to these mechanosensors, for example, can cause something called neurogenic bladder, where the detrusor muscle now just constantly kind of quivers. And so you get this contraction of the detrusor, you get this leakage. Also, infections of the bladder can also cause the bladder, the detrusor to get irritated. The urothelium to get irritated, that'll cause the detrusor to contract and you can get leakage. Also, the inflammation can swell this. That can cause pain while urinating. That's called dysuria. Dysuria. All righty. Questions about any or all of that? All right. And back to the ranch here. Here is a very, very beautiful technetium staining of the urinary tract system as it filters. You can see the calyces, see the renal pelvis, see the ureters, see the bladder filling. It's just beautiful, just beautiful. And I talked about all that. I'm just going to move on. Okay, let's talk about the blood supply to the nephrons. blood is going to enter the left and right kidney through the left and right renal artery. And I think, yeah, here's a picture of it here. These renal arteries then divide into so-called segmental arteries. Here they're called interlobar arteries. Interlobar arteries, these into the segmental arteries then are going to divide. Well, they're segmental, and as they pass between the pyramids, they get called interlobar. So this would be a segmental, this would be an interlobar artery. Then they pass into the arcuate arteries that go over the bases of the renal pyramids. Then they divide, the book here calls them interlobular arteries. Other books will call those cortical radiate arteries. Our book calls them interlobular, or excuse me. Yeah, the book calls them interlobular. Go ahead and use that name because that's what'll be on your test. And then from there, they divide into the glomeruli, the afferent glomeruli that feed each nephron. Notice the veins. The veins essentially completely recapitulate the arteries, exception being you don't have segmental veins, you have interlobar veins, and then they merge pretty much directly into the renal vein. You don't have segmental veins. The book here kind of draws it as though you have segmental veins. There are segmental arteries, but no segmental veins. Now here is a picture of a glomerulus. You can see that the glomerulus is a knot to some extent of very fine, beautiful, delicate capillaries. These capillaries are very porous. They have large pores that are 200 to 500 angstroms in diameter. And these are called fenestrae. Fenestrae, that's Fenestrae, fenestrae. Consequently, these capillaries are 100 to 400 times more permeable than other capillaries. So they allow the passage of solutes while preventing the passage of cells. So blood enters the glomerulus through an afferent arteriole. Then after it forms a little knot, it exits the Bowman's capsule via a efferent arteriole. Then that efferent arteriole is going to swing around and supply blood to the renal tubule in the form of peritubular capillaries. These will surround the renal tubule. And then the blood will be drained from the peritubular capillaries into the interlobular vein, otherwise known as a cortical radiate vein, into the arcuate vein, into the interlobule vein, into the renal vein. And this picture shows you the blood system coming from the interlobular here, or cortical radiate. It becomes a glomerulus here. The glomerulus plus the Bowman's capsule is called the glomerular capsule or renal corpuscle, depending upon which term you like. And it exits via the efferent arteriole, swings around, becomes a peritubular capillaries, and drains into the interlobular vein or cortical radiate vein, which then becomes the arcuate vein, the interlobar vein, and the renal vein. Nephrons come in two main types based on their position in the kidney. Juxtamedullary nephrons have their renal corpuscle close to the boundary between the renal cortex and the renal medulla. Their loop of Henle then goes deep, deep, deep into the renal medulla. Cortical nephrons originate in the upper 2/3 of the cortex. Their loop of Henle doesn't go nearly as deep in the medulla, and that's a cortical nephron. Cortical nephron. And this shows you the detailed structure granted in a cartoon of the glomerulus. As the afferent capillary enters the Bowman's capsule, it branches extensively, becomes very thin, very delicate, and then merges into the efferent arteriole, then becomes a peritubular capillary. All right, glomerular filtration. They still haven't turned the heat on in this room. Every room in this building is just cold. It's really cold. All right, so the glomerular capillaries are very, very porous. So they're going to leak water, solutes, small peptides, small molecules. They will not leak cells. Those pores are too small for cells. The inner layer of the Bowman's capsule contains a group of cells that are long and have a series of extensions, kind of like an octopus. And these cells with the little feet, they lay over these porous capillaries of the glomerulus, and these cells are called podocytes. Podocytes. And they have so-called pedicels, or foot processes. And these pedicels, as you can see, interlock with each other. So here's your podocyte cell body. Here's the little foot. Here's another little foot. Notice how these feet interdigitate very beautifully, and they coat these porous glomerular capillaries. Now there's a basement membrane in between the endothelium of the glomerular capillary and the podocytes. This basal lamina is very highly charged. That means whatever gets through these pores has to be able to flow through this very highly charged matrix. Consequently, virtually no blood proteins flow through this layer, get repelled. Also, cells are much, much, much too big to get through this layer. And the pedicels themselves have small pores. So through this, you will make a filtrate. I had a professor who said, think of it like a coffee filter. I'm not sure I like that analogy. Coffee filter is pretty simplistic. But if that floats your boat, go for it. But this is a filtration system. So you're going to get in this filtrate, and it'll be called at this point filtrate, water, salts, ions, things like that. So electrolytes, small molecules like glucose, amino acids, things like that, metabolites, small peptides, and waste products and things like that. That's about what you'll get in the filtrate. So the filtrate will pass through this into the layer that is the Bowman's capsule. So the podocytes have these vessels. They make, therefore, a filtrate that is very highly filtered. And here is a gorgeous scanning electron microscope picture of these podocytes. And I just think this picture is beautiful, just beautiful. But you can see the branching pedicels so beautifully. You can also see how well they interdigitate. And here is an equally beautiful transmission electron microscope section through those podocytes. And it shows you the fenestrae in the glomerulus. Look how big an erythrocyte is relative to those fenestrae. Here's the basal lamina. And then here are these foot processes with their small pores. So you're going to have a very, very highly processed filtrate. So the fluid that forms under this filtration technique is called the glomerular filtrate. And the rate at which you make that filtrate is called the glomerular filtration rate, or GFR. And the glomerular filtration rate is largely a function of pressure, blood pressure, pushing the fluid through those fenestrae, through the basement membrane, through the holes in the pedicels. The rate at which you produce that, that's your GFR, glomerular filtration rate. So that's the volume of filtrate made by both kidneys per minute. Volume of filtrate made by both kidneys per minute. Average GFR is, as you can see here, about 115 mils per minute in women and about 125 mils per minute in men. That's equivalent to about 180 liters per day, 7.5 liters per hour. There's no way you could survive losing that much fluid per day. So your kidney is going to take that filtrate and recapture much of what it wants, and it'll make something much more concentrated. And this picture from your book shows you the production of the glomerular filtrate. So your blood volume will be filtered about every 40 minutes. most of that water will be returned to the vascular system. Otherwise, you would dehydrate. You'd urinate yourself to death within minutes. You couldn't drink that much water to replace it. You just couldn't. The rate of glomerular filtration is affected by the rate of blood flow. So vasodilation or vasoconstriction of the afferent glomerulus will determine, or at least greatly influence, the GFR. And there are both intrinsic and extrinsic factors that will regulate afferent arteriolar vasoconstriction and vasodilation. So first of all, an increase in sympathetic nerve activity will cause constriction of afferent arterioles in order to divert blood to other more critical organs like the heart and the muscles. During cardiovascular shock, a decreased GFR will compensate for the rapid drop in blood pressure. Under such circumstances, the input from sympathetic neurons can be removed, but such a procedure actually doesn't radically change the GFR. Increased blood pressure will cause constriction of the afferent arteriole. Decreased blood pressure will cause vasodilation of the afferent arteriole. That again is an autoregulatory function. That's to keep GFR relatively the same during the flux in blood pressure. That is shown here. You also have renal autoregulation that's achieved through the effects of locally produced chemicals on the afferent arterioles. When systemic arterial pressure falls toward a mean of 70 torr, the afferent arterioles will dilate. And when the pressure rises, the afferent arterioles will constrict. That keeps blood flow to the glomerulus relatively constant. Autoregulation is achieved through a negative feedback relationship between the afferent arterioles and the volume of blood in the filtrate. The increased flow of filtrate is sensed by a group of cells called the macula densa. The macula densa are a group of very high epithelial cells in the thick portion of the ascending loop of Henle, where it swings back and crosses the entry and exit points of the glomerulus. I think I have one. Yeah, there it is. There it is. So that's the macula densa. Macula densa there. An increased flow of filtrate will be sensed by the macula densa. When the macula densa senses an increased flow of filtrate, it will signal the afferent arterioles to constrict. That slows down filtrate production. That lowers GFR, decreased formation of filtrate. This process is called tubuloglomerular feedback. Tubuloglomerular feedback. And here is your macula densa. The macula densa is part of a larger structure called the juxtaglomerular apparatus. This juxtaglomerular apparatus consists of the macula densa cells, which are in the thick ascending limb of the loop of Henle. These granular cells, which jut up right against the afferent arteriole, they're called granular cells because they're filled with granules. You can see quite easily in a section. And then these other cells here, these are called extraglomerular mesangial cells. Extraglomerular mesangial cells. That's M-E-S-A-N-G-I-A-L, mesangial cells. We'll talk more about the juxtaglomerular apparatus in a bit. So once you make the filtrate in the Bauman's capsule, it now will make its way through the renal tubules. Some 99% of the volume of the filtrate gets returned to the vascular system. So a well-hydrated person will actually excrete 16 milliliters, of urine per minute. Whereas a dehydrated individual may only excrete 0.3 milliliters per minute. So the amount of liquid you return to the circulation depends upon levels of hydration. There is an obligatory water loss of 400 mils per day. 400 mils per day. That's how much you have to excrete in order to make sure you're properly excreting metabolic wastes. So if you're in the desert, water, amount of urine you make is very low, but you'll still make 400 mils per day. That's not to mention the amount of water you lose via sweating, and then water vapor from breathing, so-called insensate water loss, which can add up. All right, resorption of the filtered molecules. When you return molecules in the filtrate, even water, from the filtrate back to the circulation, that's called resorption, reabsorption. To recapture water, you move ions, water comes along for the ride. There is no such thing as active transport of water. All reabsorption of water is passive. You do this by making gradients of ions, recapturing ions, and then the water will follow very obediently. So the first set of the renal tubules that are encountered are the PCT, the proximal convoluted tubules. So the proximal convoluted tubule is lined by tubule cells that also form a kind of brush border. So if you were to look essentially if you were to look at this tubule, you'd see epithelial cells, but they're going to have a brush border, not unlike what we saw in the GI tract. These are little microvilli. Nuclei. They sit on a basement membrane, like all good epithelia. These tend to be a cuboidal epithelia, and then right outside you have a blood vessel. So whatever gets reabsorbed is usually going to go right back to the blood because the blood is right next door. Just like that. And your filtrate is going to move this direction like that. Now in the PCT, various solutes such as sodium and potassium and calcium and chloride and magnesium will get reabsorbed. Sodium is probably one of the most important because it's going to help with the reabsorption of other solutes. Now these cells have in their, so this is the apical surface here. The basolateral surface is here, and in the basolateral surface, these cells are going to have little black dots, right. A sodium-potassium ATPase. Sodium-potassium ATPase. So sodium in the cell is going to get pumped out. Where? Into the blood. And potassium is going to get pumped back in. Remember, it's 3 sodium for every 2 potassium. And this is all at the expense of ATP, which I'm not going to draw on there because that's going to clutter things up. Now, because of the activity of the sodium-potassium ATPase, sodium concentration in these cells is low. That means that you will be able to use co-transport, secondary active transport, to take up many of these molecules. The other one you can take up is glucose. So the cell has in the apical membrane these transporters, and these are called sodium glucose cotransporters. Sodium glucose cotransporters. So these are going to take up glucose. So glucose is filtered. Sodium concentrations inside the cell are low. Therefore, sodium can come in down its gradient. Glucose will hitch a ride with it. And then in the basolateral membrane, you have a facilitated diffusion transporter for glucose that is called glut, and glucose therefore gets right back into the bloodstream. And this is the glut 1. There's also another one that's called glut 2 that does the same thing. So you have secondary active transport here. You have facilitated diffusion here. And then sodium gets kicked back into the bloodstream via the sodium potassium ATPase. Several other entities are taken up using these types of transporters. So there are sodium amino acid transporters that take up amino acids. Sodium is also used very often to take up many of these sorts of ions as well. So sodium is going to help essentially reabsorb many of these other components here in the PCT. So you recapture glucose, you recapture sodium through this division of labor at the surface, apical surface of the PCT cell, and then different transporters in the basolateral membrane. And that's how you reclaim sodium and glucose. And again, water comes in for the ride. So you recapture a good deal of water too while you're at it in the PCT. And you get chloride and sodium transport as well through a sodium chloride cotransporter. And in all, some 65% of the salt and the water in the original glomerular ultrafiltrate is reabsorbed by the PCT using this very strategy we talked about. Now, because you're losing water with salts, with solutes, the filtrate remains isotonic to blood. That's very important to remember. You don't change the concentration of the filtrate, you change the volume of the filtrate. Because for every bit of solute you lose back to the, you get reabsorbed back to the blood, you also get compensatory amounts of solvent, of water, returning to the blood as well. Then we go to the loop of Henle. and the filtrate will move through the descending loop of Henle, which is going to return more of the salt and water back to the vascular system. The loop of Henle does what it does regardless of the hydration status of the individual. So 2 more things before we quit. The descending loop of Henle is permeable to water, impermeable to salt. The ascending loop of Henle is impermeable to water, permeable to salt. Let me say that again. The descending loop of Henle is permeable to water, but impermeable to salt. The ascending loop of Henle is impermeable to water, but permeable to salt. And we'll get to how this works on Wednesday. All right, that's enough for today. I will hang out here a bit if you have any questions, and the rest of you, we'll see you on Wednesday.
So I have a couple of questions about biochemistry. Is that okay?